I'd like to welcome Dr. Raju, who's one of the founding members and the former president of the American Venous Forum. Over the years, he's had over 260 articles published, and he's one of the luminaries in venous disease and recognized as a worldwide leader. Thank you for agreeing to this podcast.
Anil, I want to thank you, Dr. Bush, and of course the Journal of Vascular Surgery for inviting me to do this podcast. I thought I would focus on the hemodynamics of the calf pump, particularly the column interruption duration, CID for short. Current clinical practice in the community is not up to date with regard to calf pump hemodynamics. The centerpiece of valve closure is this collapsed segment below the key valve. The calf pump and the valve work together, and you need to collapse the segment below for adequate pressure reduction. If you get good collapse and good calf pump action, you get a volume pressure curve shown on the right side. This is the famous tube law. Now, if the segment is fully collapsed, the pressure is somewhere around zero or even slightly negative. Now, the cartoon right next to the curve shows the degree of collapse. Now, when they are fully collapsed, most collapsible tubes form into two dumbbell-shaped channels with a totally flat segment in between. Now, the veins do not exactly do that. They do not, the dumbbell with the flat segment in between is more a Penrose type of situation, happens in artificial conduits, but veins probably collapse more or less concentrically. Let's go back to that figure. Yeah, more or less concentrically. They may be irregular in shape, and then the pressure hits zero when the vein is full but not distended. That means the walls of the vein are not stretched. Now, to get high pressure above zero, you really need to blow up the vein like a balloon, as you see here on the right-hand top side. Now, most veins in the body live around zero to a few millimeters local pressure. A high distension like that shown on the right side happens only when you add hydrostatic gravity component to the local pressure. For example, in the calf, when you measure the pressure in the dorsal vein, it is close to 80 or 90 millimeters of mercury. But if you disregard the hydrostatic component, the local pressure will be somewhere around 0 to 10 millimeters of mercury. Let's go to that. Now, the local internal pressure, if the vein is completely collapsed, is 0 to 5 millimeters of mercury. And the degree of collapse depends upon how well that segment empties, meaning good calf pump ejection. Both obstruction above the valve and reflux at the valve will impair ejection fraction, and the resulting degree of collapse will be affected by that. Refill time is reduced when there is incomplete collapse, and that will result in early reopening of the valve. Recovery time or refill time will be less if the segment below the valve does not empty. For example, with calf pump action, the femoral vein in the thigh does not empty well because the thigh pump is not nearly as good as the calf pump. So the femoral valve opens relatively early because there is considerable residual volume below the closed femoral valve. For this reason, the femoral and popliteal valves are known to close for relatively short periods of time with short recovery times because there is incomplete emptying, and there's also refilling from named and unnamed tributaries. It is now known that proximal valves in the thigh, that is femoral, saphenofemoral, and popliteal valves, stay closed after valve closure only for a very brief period, say 5 to 15 seconds. Collapse is most in terminal or nearly terminal veins, and that is the posterior tibial vein for the calf pump valves. And these valves in the posterior tibial vein stay closed for up to 2 minutes or more after calf pump action. A high degree of collapse of long duration in the calf is desired to give pressure relief to the calf pump. Now at the resting time on your left side, all the valves in blue are open with flow. Now after immediate calf pump action or post-ejection in the middle, all the valves in the leg from the femoral all the way down to the tibial valves close momentarily, but 15 seconds later, on the right side, the femoral, saphenofemoral, and popliteal valves in the upper thigh and leg have reopened with flow. So the remaining valves in the tibial vein in the lower third of the leg and some valves at the same level in the saphenous vein do remain closed beyond 15 seconds, and that can last up to 2 minutes. All this time, there is flow above those closed valves. Next slide. Anatomy favors column segmentation and long duration of closure in the calf pump. There are more tibial valves, about 40, than anywhere else in the body. This is not well described in our clinical textbooks, but this has been long, well-known, long-established anatomical fact. There are also about 4 valves in the distal saphenous vein in the lower third of the leg. The saphenous valves, as usual, can short-circuit the tibial valves, refilling the calf pump prematurely in some patients. So CID should be measured separately, both in the tibial vein and the adjacent saphenous vein in the lower third of the leg. Next. The way to measure it is as follows. The tibial valves are so small, they cannot be readily imaged by standard probes. However, you can determine if the tibial valves are closed, collapsing the tibial vein, or open with tibial flow present. The calf pump is ejected rapidly, inflating a calf cuff to 300 millimeters of mercury while monitoring the tibial valve flow. Flow is suddenly stopped with calf inflation, of course. Flow will reappear after 1 to 2 minutes in normal individuals. And that is the column interruption duration, or CID. So you can see in the picture the calf is surrounded by the rapid inflation deflation cuff, and with a probe we are monitoring the tibial lower third of the tibial vein for resumption of flow. This is diametrically opposite to what we do with valve closure times, right? We monitor the valve and it closes, and then within 30 seconds to 1 minute, it reopens in the femoral region, right? That is the reflux time. This is not what we are doing. What we are doing is the resumption of flow in the tibial vein after the calf has been emptied. That is, the collapsed vein segment has to uncollapse and refill. And that takes about 2 minutes, not 30 seconds or 1 minute like we normally measure for valve closure times. Next slide. Now, the purpose of collapsed segment and valve closure, ultimate physiologic purpose, is to segment the venous column, which will reduce the calf pump pressure. On the left side, everything is open, and the pressure at the foot level is 80 millimeters of mercury, because you have a hydrostatic column extending from the foot all the way up to the heart. Now, if the femoral valve closes, and that is in the groin region, the pressure in the foot will be reduced to 50 millimeters of mercury. But of course, the femoral valve doesn't stay closed for too long after calf pump, right? Go back to the figure. Because it stays open only for 5 to 15 seconds. And then it gets open. So segmentation at the femoral valve closure does not last very long. And the pressure is relatively high too, 50 millimeters of mercury. The popliteal valve, when it closes, it does better because the residual column below the popliteal valve is about 30 millimeters of mercury. But then again, the popliteal valve maximum stays closed only for about 15 seconds. The femoral valve for 5 seconds and the popliteal valve 15 seconds. The most efficient segmentation occurs at the tibial valve level. The residual pressure is reduced to 10 millimeters of mercury, and the duration lasts up to 2 minutes. So you get the best segmentation there because the pressure is the lowest and the duration of column segmentation is the longest. So the CID is, that's what we are doing by measuring CID. And it is kind of a head shake for most of us because we are all the time focusing on valve reflux. I mean, you're talking about 1 to 15 seconds to 1 minute in the groin. and that is reflux at the valve level in the groin. Here we are measuring column segmentation duration at the lower third of the leg. Next slide. The conclusion is venous Doppler developed in the 1970s was initially used to study the large proximal valves in the thigh. Clinical interest continues to focus on reflux at these valve sites. However, it is now known that these valves close only transiently with calf pump ejection, that is, durable column segmentation is not achieved at these valve locations at the groin or even the popliteal. It is also clear that calf pump efficiency is dependent on more distal valves in the tibial vein. They are much more numerous, as many as 40 in number. Anatomically, they are better suited to provide durable valve closure and column segmentation. Breakup of the hydrostatic column at this level provides the lowest calf pump pressure in comparison and the longest duration. Tibial valves cannot be imaged with standard Doppler probes, but their opening and closing can be timed by Doppler monitoring of tibial flow with calf pump ejection. CID is a high-fidelity, non-invasive surrogate for ambulatory venous pressure. In fact, it may avoid errors known to be present through the, go back please, through the multi-valve dorsal foot vein. And the key references shown here. And Dr. Hingarani, with that, I thank you, and feel free to edit it as you see fit.
Before we go, however, this is a relatively simple technique that you've described, and your data from your prior papers have suggested that it may be, as you said, highly sensitive for clinical, for the SEEP classification, and it may actually be better than some of the other ways that we can look at the venous hemodynamics. How do you see that we can use this in the, not only in research, but in the clinic, by the bedside?
Our clinical work so far has only shown that it is abnormal. CID is abnormal both in obstruction and reflux. And the ultimate aim would be to show that if you do corrective procedures, either fix the reflux or relieve the obstruction, it should improve. We don't have the data yet, so we suspect we can show that that would improve, but we are in, right now, that's what we are collecting data, and we are not in a position to say, yeah, do a stent procedure, do a venous ablation, CID improves. We don't know that yet, but we do know that SEEP classification 1, 2, 3, 4 through 6 pretty much correlates with CID.
So I think that's an important piece to mention. We're clinicians and we're interested in the SEEP classification, and we're interested in taking to the bedside and how we're going to help determine what therapies the patients would need. I have to congratulate you, first of all, because you've looked at the venous hemodynamics, I think more so than many other people for the last 40, 50 years, quite frankly. And you've been one of the progressive forces in this. I just want to ask, from the point of view from a young career, early career, a young trainee who may be interested in this, can you give them some words of wisdom who may be interested in looking at hemodynamics in the venous system or otherwise? How do they get started? How do they persist with this? You persisted in this and had amazing success.
Unfortunately, COVID interrupted our work for the past 2 years. Otherwise, we were hoping to have some clinical material with treatment to show that it improves or does not improve, to have the data available at this time. So the technique is fairly simple. I would urge those who are watching this podcast to look up these two key references. And with those references, it's fairly easy to duplicate in the clinic. It's not difficult at all. And while I am mentioning all this, the mentor for me on this is Dr. David Sumner. In fact, some of his early papers with Gooley focused on the numerous tibial valves. He noted there are 30, 40 valves in the tibial region, and he questioned, why does valvuloplasty in the femoral region work? So he questioned that, and that's where the inspiration came from. I would urge all of you who have large clinical material to duplicate this technique, and I think you will get to an answer how far useful it is in the clinical setting. Ours is in progress. We do about something like 300 interventions a year. I know, Dr. Hingrani, you do much more, so I would urge you and others with large clinical practice to try and duplicate this.
I have to congratulate you. You've been one of the people who have looked at the venous hemodynamics, and I think that you're doing this for so many decades and continue to do it is admirable and actually something that I think that we can all look forward and up to. So thank you very much for telling us about CID. I think this is important. And I think going forward, we're definitely going to be looking at this body of literature.
Thank you, Dr. Hingrani. Have a great evening.
Thank you.
Bye-bye.